Hello, this is Dr. Anthereca Lane with Cincinnati Medical Association. Today we are so excited to have a very special guest, Dr. Odell Owens. Dr. Odell Owens is the President, Chief Executive Officer, and a board member of Interact for Health and Interact for Change. He joined Interact as president in October 16. Dr. Owens holds an MD and a Master's of Public Health from Yale University Medical School, where he also completed a residency in obstetrics and gynecology. Owens completed a fellowship in reproductive endocrinology at Harvard Medical School and served as clinical instructor in reproductive endocrinology. After returning to Cincinnati in 1982, Dr. Owens established an in vitro fertilization program at the University of Cincinnati Medical Center. He achieved Cincinnati's first successful conception and delivery, as well as the first pregnancy from a frozen embryo. In recent years, he has served as the Hamilton County Coroner, Cincinnati State Technical and Community College President, and Medical Director, Interim Health Commissioner of the Cincinnati Health Department. Dr. Owens comes to us with extensive expertise and community experience as board members on a variety of organizations. It's such a pleasure to see you and have you today, Dr. Owens.
Well, thank you. Thank you for the invitation to be here today.
Our first question, Dr. Owens. COVID-19 shed light on the disparities that exist in the United States healthcare system. One of the missions of Interact for Health is to promote health equity. Please share with us some of the challenges and some of the successes on this journey to health equity.
Well, health equity and disparities is a tough topic because people don't want to deal with it, because underlying all this is racism. And I do think, though, that there is a greater acceptance to have that conversation that racism does play an important part in the health disparities among African American and other people of color. Interact for Health is a health foundation, and we approach equity through our school-based health centers. We feel that if we can provide healthcare in the schools where the children tend to have an inability to get to a doctor as quickly as other kids in more suburban areas, or the ability to have their parents take them to a physician, if we can see them at the school, especially with asthma, and 10% of all Cincinnati Public Health children have asthma, we can keep that kid in school, give them a better chance of graduating. However, when we look at our data, we've been very successful making them healthy, but they still miss as many days as kids in schools without health care because of the social determinants. I did a study of a group of kids at Aiken, and from the study, it showed that 8% of these kids had their electricity turned off twice in 1 year, and 3% had the water turned off twice. So I can make them healthy, but they can't shower, can't bathe, can't do their homework, can't get dressed, and they walk out their door depressed because they have no electricity and water. Then it's a very evolving problem, and we need more help than just the medical help.
As we experience the COVID-19 pandemic, what are the concerns that will have long-lasting impact on the African American community specifically?
Well, I think there are two things that come to mind for me when I think about the long-term impact. First is the educational piece. We have kids that will have not had a formal classroom teaching, more than likely, from March of this year until September. These are the kids that worry about are inner city kids who are already behind, who are already in schools that are not performing at a very high level. Again, not because of the teacher's fault, but again, because a lot of those social determinants that are involved. So we have a group of kids that won't recover. They're all going to be passed to the next grade.
Mm-hmm.
Many kids don't deserve to go to the next grade. They're not going to be ready for the next grade. So therefore, in the next grade they go to, the teacher's got to water down that curriculum to backtrack and teach them some of the things they should have learned in the past. In a normal school year, 70% of kids in the urban core, 70% of them will will flesh out a lot of the general information they learn. And we know that 50% of their math skills are lost through the summer in inner city schools. So this is magnified. The second part is the economy. What about their parents and their jobs?
Mm-hmm.
When we look at that, 63% of African Americans work jobs that do not provide sick days. So that tells you that we're working lower paying jobs without benefits. We're going to be the last ones called back to work because he's going to be unskilled. And many of these jobs are not going to exist. You already had parents sometimes doing 2 jobs just to make ends meet. And now these little part-time jobs are going to be gone because we're never going to be first in line.
Mm-hmm.
We won't be first in line because we will probably not have had the antibody testing. We may get tested, but we won't have the antibody testing, and that's going to be your passport back to work. So I'm concerned about the education, and I'm concerned about the economy, the African American economy. You know, today, the net worth of an African American is $3,500.
Wow.
The net worth of a Caucasian in this country is well over $50,000. That number is going to go down for us.
Yeah, I think that education piece is so important. Actually, the economy piece as well as a business owner. But I really am concerned about that education piece as I think about all the children who struggle even during times when they're sitting in front of teachers, and now they're reliant on Wi-Fi connection, internet connection, computers, technology that they may or may not have access to. It's going to definitely behoove every single leader in the educational area to figure out how to bridge that technology gap and that education gap. So that's definitely true. I know that Interact for Health does a lot of work in terms of substance abuse. In regards to substance abuse in the African American community, in your opinion, what are the substances of greatest concern? And would you consider African Americans to be in a substance abuse epidemic?
I'm not sure if I would say with a substance abuse epidemic. I think the drug problem in the African American community has just been ignored. When you look at and Interact is very much involved in the whole opioid epidemic. I think that is an epidemic, with 50,000 people in 2017 dying of overdose. But really what happened is that in the opioid sector, African Americans were initially left out. African Americans, both adults and children who presented themselves to the emergency room with injuries or a situation where they needed pain medication, the system said, no, we're not giving opioids to African Americans because they're drug addictors. They're seeking drugs for their drug addiction. And they freely prescribed it to whites. And so when you look at the overdose rates, up until the last 2 years, it was extremely low for African Americans because they didn't have access to it. It certainly changed a little bit around 17 or 18. But even society looked at things differently. When African Americans were addicted to cocaine, we were addicts. But when the opioid came in and it began to impact doctors and lawyers and business people, it became a disease. African Americans lost out because then there was this priority to fill the residential beds with people with the opioid addictions, and African Americans with the cocaine and alcohol kind of pushed out the door. Mm-hmm. You had police stations that will allow you to bring in your opioid and turn it in and not be arrested, but they never made that offer to African Americans to bring in their crack cocaine and not be arrested. We never saw a prosecution of a crack cocaine dealer, but you did see that with an opioid dealer who sold dope and someone died from it. He got prosecuted. But all these years, we've not seen that in the African American community. So there's been a real difference in terms of what's available. African Americans had to go to clinics to seek treatment. With the opioid, people were able to go to a doctor's office. It was private. You could get certain kinds of medication. So there's been this discrepancy, and this is why Interact's involved, because looking for issues of equity. How do we go in and help? Even here in Hamilton County, I look at the reports on a daily basis on trips to the emergency room, EMS trips, and we're seeing very few African Americans Where we saw that initial rise is when the drug system began to add fentanyl to the crack, or began to offer fentanyl to African Americans. In the 7 years that I was the coroner, I was also responsible for running the forensic laboratory. And in our laboratory, we did all the drug testing for the county. In those 7 years, didn't really see a case of methamphetamine in the inner city. If you recall, methamphetamine started out as a white biker's drug. It was the Hells Angels who made meth and sold meth. But meth couldn't penetrate the inner city because the drug forces controlling the inner city sold the marijuana and crack cocaine. But that's beginning to change as well when meth is now seeping into the African American community. One of the reasons that meth has become so strong is that people are afraid of heroin, because when they buy the heroin, it may be mixed with fentanyl, and that's where the high overdose rate was coming from. So people are afraid of that, so they're shifting back to meth. However, the meth is now pharmaceutical grade coming from Mexico, where the fentanyl is pharmaceutical grade coming from China. So in the African American community, we still doing our crack. People are trying to infiltrate the crack with fentanyl, but we still do a lot of marijuana. It's probably the most abused drug in the African American community is marijuana.
In your opinion, why should African Americans remain on guard during the opioid crisis?
Well, you know, my concern is that when you look at the data right now, things have been kind of stable. It's a little bit frightening because you would have suspected that with the sheltered in, people would have been more stressed and probably use more dope. However, because our borders have been somewhat shut down from China, where the fentanyl is coming from, and meth from Mexico, people are probably cutting their drugs. When I say cutting, you know, they're adding other substance to stretch it so that it's not as powerful, and therefore they probably are tolerating a lot more discomfort because they can't get the medication. Now, again, because they're sheltered in, you have to understand that subculture people get their money from robbery, stick-ups, and so that has been shut down because you don't have the bars where people get robbed a lot, people not on the street. So the money's not there to even buy some of the drugs for those people who depend on crime to support their habit. So the Black community has to be on guard because we're smoking more, and you know that's a disparity between Blacks and whites. In Cincinnati, 30% of the population smokes menthol cigarettes. 70% of Blacks smoke menthol, only 20% of whites. So we've been targeted for that. Menthol cigarettes are the easiest cigarettes to start with, but they're the most difficult ones to stop. So doing this, when people are more stressed, they're going to smoke more. They certainly have the urge maybe to do more drugs, but the drugs may not be there. So this is a time for the African American community to step up and get treatment, do smoking cessation, and go to treatment facilities.
That brings us to our next question. As an obstetrician, I have recognized an increase in the prevalence of marijuana and tobacco during pregnancy. According to an article from the American College of Obstetricians and Gynecologists, the prevalence of the marijuana use is approximately 2 to 5%, and this is with individuals reporting their use. This percentage actually increases to 15 to 28% in young, urban, low socioeconomic communities. According to the CDC, although African Americans usually smoke fewer cigarettes and start smoking cigarettes at an early age, they are more likely to die from smoke-related diseases. In general, should we be concerned about the level of marijuana and tobacco use in the African American community? And can you elaborate more on why we should take these two substances more seriously?
Yes, now Interact for Health has been very active and was able to get the city of Cincinnati to pass Tobacco 21. And that is an ordinance in Cincinnati as of last December that one must be 21 years old to purchase any tobacco product, not just cigarettes, but any tobacco product. The philosophy behind that is that about 85% of people, if they're going to smoke before the age of 18. It is rare to see someone start cigarette smoking after the age of 24. So if you can get that group before the age of 18, Now, by passing Tobacco 21, that means that you're not going to have anybody in the high school who can illicitly buy cigarettes and pass to their classmates. They're going to be too old. They're going to be off to college. So you're going to make it more difficult. However, we noticed that starting in the year 2016, that the smoking rates among teenagers plummeted. But we also saw that the vaping rates went the opposite way. So when you look at marijuana, as you know, the infant mortality rate in Cincinnati and Hamilton County over the past few years was on its way down. And then it plateaued. And when they began to really dive a little deeply into this, they began to look at women who said, no, they didn't smoke or they didn't use marijuana. But when they started doing the testing, they saw a great discrepancy. So people weren't being honest. And so it was felt, at least here in Hamilton County, that the plateauing 2 years ago of the infant mortality rate was due to cigarette smoking and smoking marijuana. As African Americans, we don't need anything that's going to impede us from getting a full life. Our life expectancy for Black males is lower than for a white male. Our life expectancy for a Black female is a little lower than for a white female. But we also have so many underlying medical problems. If we look at cigarette smoking is the number one preventable cause of death. You can give up cigarette smoking, you're going to live longer because it impacts your diabetes, your heart disease, and your lungs. So those are two things we really have to work on. And with the COVID-19, which is going to be around for the next 2 years, certainly smoking, whether it's marijuana or cigarettes, are going to impair your lungs, that if you do get the virus, you're going to have a more complicated case.
So how can African Americans protect themselves against pandemics that directly impact those individuals with chronic illnesses that are prevalent in our community?
Well, first of all, we got to go back to the disparities. First of all, do we have our underlying medical problems addressed appropriately? If we start with diabetes, is the diabetes well controlled? Are individuals going to see the physician, or they're sticking to a diet? The African American family is very complicated. I've noticed that many times you would have a single individual in a family have diabetes. And in a Black family, they will make a special meal for that person. In a white family, then the whole family changes their diet. So oftentimes in the Black community, that one person is isolated with a special diet. And then grandma will say, oh, honey, you can have one slice of pie. One slice of pie is not going to hurt you. So we don't necessarily take it as seriously as we should. Hypertension, the question is, are we treated to goal? In this country, probably 40% of all people on hypertensive medication are not treated at goal. Oftentimes, physician will get satisfied with 140 over 90 or 95 when a person came in at 180 over 110. But studies say you got to get down to that below the 120 over 180. So we're not even at the goal, so the hypertensive medication is actually protecting our body. When you should look at obesity, for a long time, African Americans worked very hard jobs. And historically, an African American man or woman coming home from a hard day's work, they viewed sitting on the couch as their reward for a hard day's work. They weren't going to get up and go exercise because they've already exercised by the hard work they've done that day. So we have to sort of change the culture about exercise and the type of exercise that people can do that can be fun. So it's a real cultural swing for us.
Yeah, I think you've brought up some very valuable points in regards to our lifestyle, our culture, that all contribute to the chronic illnesses that are in our communities. I think that point that you made about treating blood pressure to goal is a very valuable point. Any person who is listening to this interview today should think about whether or not their blood pressure is being treated to the appropriate goal. And if not, they need to begin to advocate for themselves and have that conversation with their physician. How would you encourage someone to have that conversation with their physician to say, hey, why isn't my blood pressure being treated to the appropriate goal?
Well, again, it's part of that cultural shift where so many African American patients have come through the clinic system where they never challenged the doctor. And but when I was the interim director of the health department, I would actually find employees who referred to the health department's health centers as clinics. I said, no, we're a health center. Because once you start using that word center, it's about respect, and the patient's viewpoints must be listened to, valued, and responded to. So you have to change both sides of the equation. You have to have it where the healthcare system is willing to listen to you. Far too often, physicians are so busy that patients get dismissed, and African American patients probably get dismissed more than anybody else. So patients must read, talk to other family members, take their own blood pressure. Every time I go to CVS or Walgreens, I go over and I sit down, I take my blood pressure just to see where I am. And so I think patients should take their pressure outside of the office. And when they get that pressure, say to the doctor, what is my pressure? Show interest in your results and ask questions at that time. If not, take someone with you who can help you ask those questions, as well as help hear the answers.
Yes, I think that's extremely valuable. One of the values in my practice is the concept of collaborative care. And really, the patient-physician interaction is actually a relationship, and there's a give and take on both ends. So I think that is extremely important. As we move on to our last question, Dr. Owens, why is it important to have African American physicians on the front line of a pandemic such as COVID-19?
Well, I think you have to have African American physicians and more African American physicians in our general population, regardless if we're a pandemic, epidemic, or no-demic. But I think you have to have people in the lead that patients can respect and understand. We understand the culture as African American physicians. When I was I think a medical student, we were seeing patients, and the chief resident was interviewing this African American woman. She was in her 70s, and when she told him that on Sundays she cooks fried chicken and bacon grease, and he just went crazy. All that cholesterol. So he started telling her about putting turkey wings in her greens and giving up the fat back, and I just said to myself, that's going in one ear and out the other ear, because he doesn't understand that Sunday meal is pleasure to her. She has very few pleasures. Now, what he needed to do was try to negotiate and say, okay, you're going to go ahead and have that chicken, but maybe then you will consider a turkey wing in your greens to negotiate. But Black people, we can do that. I saw patients that were asked if they had diabetes, and they said no. They said, but I do have a sugar problem. So as Black physicians, we have to do two things. One, we understand the language, but two, begin to tell people, no, it's diabetes, so they can begin to understand what they really have. I don't think you can replace, all doctors should have empathy and compassion, but I think African American physicians just have a better overall or holistic sense of that individual patient, not just the medical issue, but the social issue, the housing issue. Because I can give you one data point, and you can give me a lot of information where a white person can't, because we've experienced that either directly or because of people that we've been associated with. So you need African American physicians, and certainly in a pandemic of this kind of pandemic, where African Americans seem to be affected at a disproportionate rate, you're going to have Black voices that Black patients will listen to and pay attention to.
One of the voices of the Black physicians in Cincinnati is the Cincinnati Medical Association. And anyone who's listening today can go to cincinnati-medicalassociation.net. Thank you so much, Dr. Owens, for sharing your expertise, your insight, those bits and pieces of history with us today. This has been Dr. Anthereca E with Cincinnati Medical Association.